Hello everybody. We talked in the last video about renal replacement therapy in ICU, and in this video we'll talk about complications of RRT or renal replacement therapy in ICU. We can divide complications of RRT into 5 categories. Number 1, vascular access complication. Number 2, anticoagulation. Number 3, circuit related complication, and number 4, complications related to setting and others. Regarding the vascular access, there is a complication related to catheter placement, like hematoma during puncture, pneumothorax, especially with subclavian access, and also there is bleeding and arterial puncture, and it can cause arrhythmia. There is infectious complication like exit site infection and the catheter-related bloodstream infection, and we'll talk about both and differentiate between them. Non-infectious complications that happens in less than 7 days, like vessel wall injury, like malposition and kinking, and this is usually occurs during manipulation of the line. There is non-infectious complication more than 7 days, like thrombus formation, like central venous stenosis, like air embolism during removal. One of the most common complication for vascular access insertion is pneumothorax. It usually happens with subclavian approach more than internajugular. We can diagnose pneumothorax by chest X-ray or by CT chest or by lung ultrasound. As we can see in this X-ray, we can see that there is pneumothorax in the right side, and in this CT chest there is pneumothorax in the left side, and in this lung ultrasound we can see a barcode sign or stratosphere sign, which is pathognomonic for pneumothorax. Another common infection is bloodstream infection, and it usually happens with a femoral access more than jugular access. So you have to be careful during insertion of dialysis line that the area or the media is very clean or sterile. And here there is 2 types of infection. Number 1, exit site infection. There is inflammation below 2 centimeters around the catheter with no positive blood culture. But catheter-related bloodstream infection or CLABSI, according to the definition of Infectious Disease Society of America, we have 2 positive blood cultures, one central and another one is peripheral, with colony count in central sample 3-fold more than the peripheral sample. If we used a high dose of anticoagulation, this can result in bleeding, and if we used a low dose, this can cause filter clotting, and this decreases the lifespan of the filter. For the type of anticoagulation we use, if we used systemic anticoagulation with heparin, the most common complication is thrombocytopenia, and if we used regional anticoagulation with citrate, we can have complications of citrate like citrate overload. If we give more citrate than the needed for anticoagulation, this can result in citrate overload, and this can result in metabolic alkalosis, and if the body is unable to metabolize citrate, this can result in citrate toxicity and metabolic acidosis, and if we didn't replace calcium at the end of the circuit, this can result in hypocalcemia. After that circuit-related complication, number 1 is hypothermia. When blood runs through the extracorporeal circuit, it loses its temperature, and this can cause hypothermia, and it usually happens in around 50% of the cases, and this can induce shivering, which increases the metabolic requirement of the patient, and also hypothermia can result in coagulation disorders, and it masks fever, so there is delayed recognition of infection. The new designed filter or membrane for dialysis is usually less incompatible than the old one, but incompatible membrane can result in complement activation and hypersensitivity, but actually it is very difficult to conclude that there is a complication related to membrane bioincompatibility. There is a risk of filter thrombosis, like filter clogging, if we used inadequate anticoagulation, and if we used a higher dose of filtration fraction more than 25 milli per kg, there is a risk of filter clotting. For complications related to setting, number 1 is hemodynamic side effects, and this usually happens in intermittent hemodialysis than CRRT, and the most common is hypotension. Hypotension usually happens in predisposed patients with hypovolemia. When we do dialysis, the blood is filtered and the fluids removed from the blood, and the body compensates for this by transcellular shift of fluids. If the rate of removal of fluids is more than the replacement fluid from the interstitium, this is usually result in hypotension, and we mentioned that it usually happens in predisposed patient with hypovolemia. Other causes of hypotension in dialysis may be septic shock, may be cardiogenic shock, and other causes of shock. Dialysis also may cause hypokalemia, and this can result in cardiac arrhythmia, so be careful about the dose of potassium you add to the dialysis. Hypocalcemia and myocardial stunning may also cause hypotension. We can prevent this with hemodynamic monitoring during dialysis, and we can use CRRT instead of intermittent hemodialysis, and we can correct hypovolemia during dialysis with hyperoncotic solutions like albumin. Electrolytes and acid base errors. Number one, hypokalemia, and we talked about hypokalemia before, and we know that in addition to potassium, phosphate is added to the dialysate, so be careful about the doses. If we use the citrate anticoagulation, we have to replace calcium at the end of the circuit to prevent hypokalemia, and one of the complications of citrate anticoagulation also is hypomagnesemia, so you have to replace magnesium. Also, one of the causes of hypokalemia in treatment of severe cases of metabolic acidosis, transcellular shift of potassium happens with correction of acidosis, so this results in hypokalemia. Dialysis disequilibrium is one of the most common complications that happens in patients who start dialysis for the first time, and this usually happens due to rapid change of plasma osmolarity due to rapid change in urea levels, and urea one of the most important component of plasma osmolarity. So with the change of levels of urea, usually osmolarity change, and this result in a rapid shift of fluids to the intracellular part, and it can present with symptoms of headache, nausea, tremors, dizziness, muscle spasms, seizures, up to coma and cardiac arrest. And we can prevent this with decreasing the rate of solute removal and the duration of the first session of dialysis. During dialysis, macro and micronutrients are removed during renal replacement therapy, and with CRRT, around 10 to 15% of infused amino acids can be removed from the extracorporeal circuit. So it's very difficult to assess the nutritional needs of the patient on dialysis. Loss of drugs during dialysis is very complicated. There is many drugs that is renally excreted, and this usually requires dose adjustment. Protein-bound drugs are not easily removed with dialysis, and when we need to calculate the dose of any drug during dialysis, we have to account for a change in pharmacokinetics, and there is a change in clearance also, and there is hypoalbuminemia and a change in volume of distribution. Intermittent hemodialysis, we can assume that GFR is below 10, and we can calculate the dose depending on this. And usually the most important drug that needs adjustment is antibiotics. Many types of antibiotics. There is concentration dependent antibiotics, and there is time dependent antibiotics, and there is also a loading dose. Usually the loading dose of hydrophilic component like aminoglycosides, this needs a higher dose of loading because there is a higher volume of distribution. Usually the concentration dependent antibiotics will change the interval of the dosing, and for the dose dependent antibiotics we can decrease the dose. Other uncommon complications that happens in CRRT, like anemia, there is a blood loss in the circuit, and this may result in anemia. Hemolysis also can happen as blood is running through the extracorporeal circuit, and there is a shearing forces of RBCs, and this can result in hemolysis. There is hypoxia also after starting renal replacement therapy. There is decrease in BaO2 by around 10 to 15 millimercury, and this can be significant only in patients with multiple comorbidities and the patient with shock states. So our home message when you start dialysis for a patient, either on intermittent hemodialysis or CRRT, you have to monitor hemodynamics, you have to monitor his electrolytes, and monitor for bleeding and anticoagulation problems. You have to recognize dialysis disequilibrium syndrome early and treat other electrolyte disturbance very fast.